All right, let's jump straight into the Step 2 CK Final Sprint Explainer on geriatrics. We're strictly focusing on pattern recognition and hunting down that one specific clue that completely flips your management. Let's go.
Okay, case 1. An 82-year-old with a history of Alzheimer's presents with new onset lethargy and inattention over the last 48 hours. Vitals are totally stable. So what's the most likely diagnosis here? It's hypoactive delirium. The acute change and the inattention, those are your defining clues. Now, don't fall for the progressive dementia trap. That would only be the correct answer if the patient's decline was gradual, happening over months, not just a couple of days.
Moving to case 2, we've got a 74-year-old ICU patient pulling at his lines and seeing spiders. His vitals are stable, and there's no severe danger to himself or anyone else. What is the best next step in management? It's reorientation along with providing hearing and vision aids. You see, non-pharmacologic management is absolutely key for hyperactive delirium when there's no severe danger. Watch out for the lorazepam trap. That's really only correct for severe alcohol or benzodiazepine withdrawal.
All right, case 3. An 85-year-old is violently striking a nurse and actively trying to jump from a hospital window. What's the best next step? Off-label, low-dose antipsychotics like haloperidol. The immediate severe risk of physical harm absolutely justifies this. You want to avoid physical restraints here. Those are strictly a last resort if medications completely fail and extreme danger still persists. Case 4. A 75-year-old with BPH has been sleeping a lot more for the past week and now has acute urinary incontinence with a palpable bladder. Thus, next step, get a urinalysis with culture. Acute incontinence is a huge red flag for a reversible infection or delirium. Do not make the mistake of falsely reassuring the family that this is just normal dementia progression. For that to be true, you'd need to see a multi-year gradual worsening.
On to case 5. A 72-year-old woman acutely answers, "I don't know," to memory questions and is highly distressed by her cognitive decline. What's the most likely diagnosis? Pseudodementia or major depression? The sudden onset, her clear awareness, and that extreme distress really give it away. Now, Alzheimer's dementia is a tempting answer, but that would present with an insidious onset, confabulation, and a complete lack of awareness regarding her own deficits.
Case 6. A 76-year-old forgets the names of acquaintances, but she independently manages her complex bills and her medications without any help. Diagnosis? This is normal aging. Her full independence in all activities of daily living is perfectly intact. Mild cognitive impairment is incorrect here because that actually requires a noticeable cognitive decline where the patient has to actively compensate just to maintain that independence.
Let's look at case 7. An 80-year-old gets lost in his own neighborhood for hours and can no longer safely use his stove. What's the initial diagnostic workup? You need a CBC, B12, TSH, CMP, and a CT or MRI of the brain. You absolutely must rule out reversible metabolic causes and structural issues first. A lumbar puncture is the trap answer. Reserve that strictly for atypical early onset dementia or if you suspect normal pressure hydrocephalus. Case 8. A 77-year-old comes in with a 6-month history of progressive cognitive decline, vivid visual hallucinations, physically acting out his dreams, and new cogwheel rigidity. What's the diagnosis? Lewy body dementia. You've got the core triad here, fluctuating cognition, hallucinations, and Parkinsonism all starting around the exact same time. Idiopathic Parkinson's disease is wrong because it requires unilateral motor symptoms to appear years before any cognitive decline shows up. Case 9. A 70-year-old with a 5-year history of Parkinson's is on a dopamine agonist and suddenly develops highly distressing auditory hallucinations. What is the best next step? Reduce the dopamine agonist or add a low-potency antipsychotic like quetiapine. What we're seeing is medication-induced psychosis from dopamine overload. And whatever you do, avoid haloperidol. Typical antipsychotics will severely worsen his Parkinsonian motor symptoms.
All right, case 10. An 81-year-old with long-standing hypertension and CAD shows a stepwise memory decline and prominent executive dysfunction. Most likely diagnosis? Vascular dementia. The high vascular risk factors combined with that classic stepwise decline point straight to this. Frontemporal dementia is the trap, but that would require early apathy, disinhibition, or hyperorality way before the memory loss actually hits. Case 11. A 74-year-old presents with a wide-based magnetic gait, new urinary incontinence, and progressive cognitive dysfunction. What is the best initial diagnostic step? The Miller-Fisher lumbar tap test. This confirms the classic NPH triad, wobbly, wet, and wacky. Now, VP shunting is the ultimate treatment, sure, but it's only the correct answer after the tap actually proves a marked improvement in their gait. Case 12.
An 88-year-old taking over-the-counter diphenhydramine for sleep and oxybutynine for bladder spasms presents acutely confused with dry mouth, blurred vision, and urinary retention. Diagnosis: anticholinergic toxicity. This is driven by the massive muscarinic receptor burden from combining those medications. Opioid intoxication is the distractor here, but that would present with severe respiratory depression and pinpoint pupils, not dry mouth and large pupils.
Case 13. An 84-year-old is given oral diazepam for anxiety and becomes highly aggressive and confused within 1 hour of administration. What is the diagnosis? Paradoxical agitation. Notice the acute timing immediately following a benzodiazepine dose in an elderly patient. This isn't sundowning. Sundowning happens predictably every single evening as the light fades, entirely independent of new acute medications. Moving right along to case 14, a 79-year-old is found unresponsive with a respiratory rate of 6 but has normal 3 mm reactive pupils and normal bowel sounds. Most likely cause? A benzodiazepine or alcohol overdose. Severe respiratory depression with normal pupils is the dead giveaway here. Acute opioid intoxication strictly requires pinpoint pupils and absent bowel sounds alongside that respiratory depression. Case 15. A 76-year-old slaps his right foot on the ground while walking. His exam shows a steppage gait, weak foot inversion, weak plantar flexion, and radiating lower back pain. Cause? L5 radiculopathy. The defining features are the foot drop combined with inversion weakness and back pain. Common perineal neuropathy is tempting, but it lacks back pain, preserves plantarflexion, and totally preserves foot inversion. Case 16. An 82-year-old with dementia appears glued to the floor. He freezes with start and turn hesitation, using a wide base. What type of gait is this? Gait apraxia, also known as a frontal gait. That magnetic freezing and turn hesitation are classic. A Parkinsonian gait would present very differently. Think short, shuffling steps, a stooped posture, and a resting hand tremor. Case 17. An 80-year-old falls due to orthostatic hypotension. A quick review shows she's taking 3 different beta blockers prescribed by 3 different specialists. Best intervention? Medication reconciliation and a simplified regimen. Your priority is fixing those duplicate prescriptions to treat the iatrogenic cause of the orthostasis. Recommending intensive physical therapy alone is a trap because it completely ignores the dangerous polypharmacy that's actually causing the falls. Case 18. A 78-year-old with CHF is discharged after her 3rd admission for fluid overload because she keeps mismanaging her complex diuretic schedule at home. Best hospital intervention to reduce readmission? Early telephone-based outreach and care coordination. Direct follow-up improves outpatient adherence and catches clinical decline early. Discharging her to a skilled nursing facility is the trap. It's way too restrictive unless she has completely failed all ADLs and lacks any home caregiver. Let's check out case 19. An 88-year-old requires maximum physical assistance for feeding, bathing, and toileting. Her sole caregiver, her daughter, was just hospitalized for a heart attack. What's the appropriate discharge disposition? This is an unsafe discharge, requiring a skilled nursing facility. The home environment is currently unsafe with 0 caregiver support for dependent ADLs. Home health care is incorrect because it requires a capable, reliable caregiver already present in the home for the hours when home health staff aren't there. Case 20. A fully competent 75-year-old man privately admits his husband hits him, but he explicitly refuses to press charges or leave. Next best step, assesses immediate safety and provide emergency resources. You absolutely must respect the autonomy of a competent adult while offering support. Forcing police involvement against his will is a trap that's only legally mandated if he lacked medical capacity or if he was a minor. Case 21. An 85-year-old with severe nonverbal dementia presents from home with stage 4 pressure injuries, severe dehydration, and unexplained shaped bruises on her torso. Required next step? Address her immediate medical needs and report this to Adult Protective Services. Mandatory reporting applies to dependent adults with signs of abuse or severe neglect. Don't fall for the trap of aggressively confronting the caregiver. That risks alienating them or increasing harm before the patient's safety is actually secured. Case 22. A 78-year-old with early Parkinson's and an intact MoCA score wants to leave against medical advice despite a severe blood infection. He clearly states he understands he might die. Best course of action? Allow him to leave. He demonstrates full capacity and clearly understands the consequences. Remember, a neurologic illness doesn't automatically mean incapacity. Treating him under implied consent is the trap. That only applies in a true emergency if acute delirium or unconsciousness compromised his understanding.
All right, case 23, our final case. An 82-year-old inadvertently receives a 10 times dose of IV opioids due to a decimal error. He requires intubation, but fully recovers 3 days later. What is the required action? Disclose the error promptly to the patient and family and apologize. This is an active error where harm actually reached the patient. Documenting it internally but hiding it from the patient is the trap. That's only an option for a near miss that was caught before the medication ever reached the patient.
To wrap this explainer up, lock in the 60-second checklist. Verify acute versus chronic changes. Always check attention, review that medication list for polypharmacy, and establish functional independence. Assess patient capacity and confirm a safe disposition before discharge. Use this framework, and you'll catch that one crucial clue that flips your management on test day.